here's a question from Emily Evans. She writes, it seems that to be administering an assessment of organizational readiness like the ORIC, you must already have a relationship with a facility, and having high levels of organizational readiness seems like a definite asset. But what about the facilities that don't seem to be organizationally ready or at an early stage of an implementation project? In our current phase of learning health system work, would you recommend starting with facilities that are more ready, or modify your implementation strategies to address the specific challenges within each facility, or go forth with your project knowing that you will have barriers to success? It's a long question. It's in the chat.
Yes, I'd go with option one, if possible, is to select the sites that are already at a higher level of organizational readiness. If that's not an option, then spend some time on building that readiness, right? It's modifiable. And so I would rather spend time building up the readiness, or the components of readiness that we know are important for the intervention, versus just diving right in, knowing there'll be additional barriers.
Can you speak a bit about how you recruited sites into the COMPASS trial, and on what was the criteria for getting these sites in the beginning?
Well, yes, this is Pam Duncan. We had 110 healthcare facilities in North Carolina, and we only excluded those who really didn't have EDs or who accepted stroke patients. And I got to maybe Cheryl can remember from memory, but after that, there were about 95 that were ready, and we actually approached all of them. The advantage that we had is that we had a program called the Coverdale Registry, in which there had been a lot of quality programs going on through the state. And then at that point, we had to seek the health systems, and originally we were hoping to get about 50 plus to participate, but some of the health systems were very anxious to do it. It was relatively easy to recruit them. Some of them felt that it was competing with their, as Dr. Bushnell said, it's not our book of business. We are big acute stroke centers. The academic medical centers in the state were absolutely the hardest. And because they have a predisposition that, well, they fly them in, they're out of our control after we, send them out. That was a challenge. Some places says we already have, it was in the midst, it was right in the middle of the uptake of readmissions programs. And they said, well, we already got it. Why do we need a stroke specific one? So those were some of the issues. And the third one was really the health system leaders said, we aren't going, the PCORI does not pay for the intervention, and the health system leaders weren't willing to staff it in order to accomplish it or to set up these new services. And honestly, so those are the major issues that drove recruitment or not. And we worked to the wire to get the hospitals that we wanted. Yeah, that's it. But they ended up being very representative from the mountains to the sea. The thing that don't get lost in this presentation is that the rural hospitals did better than the big mega centers because, honestly, in the rural communities, they all know each other, right? And the rural communities did a great job, which is not usually the case in some of these, right? So the rural communities did great.
Oh,
Yeah, they don't have the hierarchy to try to, in the bureaucracy. It was just a little bit easier to get things done, I think, in the rural settings.
There was a question that was asked earlier that we hadn't gotten to after Dr. Duncan's talk from Michael Gotti. He asked, you mentioned that you collected SDOH data electronically. Did you use a standardized tool or set of data elements? And is that instrument or data set publicly accessible?
So what we did in terms of the patient-reported outcomes, is that what you're asking? I didn't hear.
He's asking about social determinants of health.
Oh, yes. So no, we created our own, and it was, and I do think this is important, because we tailored it to the stroke needs, right? So there are the typical food insecurities. Do you have transportation? You know, do you feel, there are the core ones that are in every electronic medical record now. And whereas a couple of those we use, obviously transportation, but it's asking you specifically in this population, can you afford to buy your medicines, right? You're going home with your medicines. We targeted specific functional deficits. We also wanted to know their caregiver support. So we really expanded it and targeted it for the things that we know from post-acute care that drive it. So it was
Yeah, I think there's an interest in knowing if you have these set of questions, if they're available for others who might like
yeah,
to.
I think in the article, if you look in the, we can just email me and we've laid that out. And we do have proprietary algorithms that we take the responses of those and immediately generate the care plan. But there are things, I mean, things like, you know, you can't go in, this was a surprise to the clinicians. And oh, by the way, in congestive heart failure, the same thing happened in our tool. We just used 3 simple items of screen. We didn't do the MOCA, you don't have time in a quick assessment, but it triggered whether you needed an additional one. But we targeted it for the fact that, especially in blood pressure control, you need a couple of key functions. Do you have an executive function? So we use the oral trails A. We also ask, can you recall, right? And 5 items, and then do you know time and date? So if you don't know those 3 basic things, it's not likely to go manage 5+ medications, right? So we tailored it.
Great. So I'm wondering now if you each want to just close with your thoughts about your things that you learned and key messages, briefly, key messages for those who are wanting to do this type of work, multi-component intervention and scaling up a multi-component intervention in a pragmatic trial. So key lessons learned.
Let me lead off, and then I'll turn it to Dr. Bushnell as a frontline and Dr. Gazelle as, but be courageous and be willing to learn and adapt. This is not changing healthcare systems or engaging them is rolling the rock up the hill. But we all know the crisis in healthcare. So how do you go about doing this? As Dr. Bushnell said, just the most amazing teamwork in the world. But the second message that I wanted you to leave with, I think was buried in our presentation and is going to be in our final draft report that will be reported, is that we also have to critically evaluate several things. Number one, these patients, mild TIAs and strokes, they are heavy healthcare utilizers in 1 year. And what we now have come to appreciate, this transitional care models were developed to reduce hospital readmissions. And the whole literature on that now is very mixed. Most of them are not showing the effect that they thought. You don't change the trajectory of a person's health with a one-time visit. And so that we need to expand the models of managing these patients. And that's what Dr. Bushnell and team are doing as we're going forward with the new submission that everybody keep their fingers crossed, because you learn. It's called a learning health system. It's a learning researcher. And we learned, and now we're refining that model. And that's what learning is about, right? Dr. Bushnell?
Yeah, I see there's a question in the chat about telerehab. We're not actually doing telerehab. We are using telehealth in our new model so that we can overcome the barrier of patients who may have transportation challenges. So I think that's just a clarification, unless Pam had a specific telerehab intent there.
Yeah, so one of the things I didn't bring it up is that with the explosion of COVID, we've moved to telehealth and telerehab, faster transition than we've ever expected in our lives. And Dr. Resnick and Janet Bedker just wrote a very important piece that with the explosion of telerehab, it's absolutely the perfect model to evaluate it in a learning health system model. And that is exactly what we did at Wake with our telehealth approach. Dr. Rory Stroud, Dr. Rory Stroud and Dr. Lauren Strauss and the whole team really have in the process of doing this, and I put references in there for you, did this. So what the model that Dr. Bushnell and team are building now could add on telerehab, and that could be a resource that would be added, that could be readily available, but it would be billed and serviced as usual. So and one other comment with that, it's just an exciting time. I wish I were 50 years younger, but there we are. It's going to be up to you now. Okay. Sabina.
I think the only other comment that I would make is that it's so important to listen to your patients. And that is really what drove a lot of what we did. And so I think that was just critical. Caregivers, patients. Of course, the health system is important too, but we were funded by the Patient-Centered Outcomes Research Institute. And so we kept that front and center.
And the requests were always reasonable. It wasn't outlandish. It was just how do you implement it that often was the challenge. I think the last comment I'd make is that when you design a pragmatic study, it's sort of on a continuum from classically controlled trial to a pragmatic trial. And we went very pragmatic. And if we were to do this again, might go a little less pragmatic on some elements, just to ease the project and the burden.